antimicrobial stewardship, improving clinical outcomes by optimization of antibiotic usage. Now I'll be following this outline. We'll talk about introduction, and we'll understand the rationale why we need an antimicrobial stewardship program. I'll talk to us about the aim of antimicrobial stewardship program. I'll discuss the various strategies used in antimicrobial stewardship program, and then the step that leads to a successful antibiotic stewardship program implementation in hospitals. Now, we all agree with me that antibiotics are among the most frequently prescribed class of drugs globally. And it's been estimated that approximately half of these use in hospitals are actually inappropriate. Now, if the use in hospitals, meaning usage in humans, 50% are inappropriate, we can imagine the usage that will be occurring in other non-human uses. It's been advocated that 85% of antibiotics are being used in non-humans, and 75% of these use are actually not therapeutic, meaning beyond uses of antimicrobial agents in human beings, they actually use it for animals too. And this use is actually based on various reasons. People want to increase the yield of their poultry farm. They want to increase they want to fatten their animal to increase their grade gain. So all these non-therapeutic uses of antimicrobial agents cumulatively expose microorganisms, both in human and non-humans, to these antibiotics. And the total consumption of antibiotics is actually one of the greatest drivers of antimicrobial resistance. So because of the unnecessary selective pressure that the antibiotics will be placing on microbial agents, it leads to development of resistance among these organisms. Now we have to do something to actually stop this, and this is one of the aims of any antimicrobial stewardship program. But before I go ahead to discuss these programs, I would like to talk to us about how these antibiotics are actually used or misused or even abused. In our hospitals at various clinics, a lot of people treat fever. They assume any fever is an infection, and they believe patients deserve to use an antibiotic for it. It's not necessarily just doctors. Almost all health workers, or even people that are not healthcare workers, actually prescribe antibiotics for patients. Once they see fever, they'll be like, let's use antibiotics for it. But we must know that not all fever are caused by infectious agents, and not all infectious agents are actually bacteria that antibiotics can work for. So because of treating people with trivial infection or non-infectious agents or even viral infections with antibiotics, this amounts to the misuse or abuse of antibiotics. Then a lot of our prescribers don't even understand the basic principles of antibiotics. Citing an example here is I came across some set of doctors at one time they were giving neonate augmentin. They will reconstitute the augmentin, then keep in the fridge for like 48 to 72 hours because the babies will be using minimal doses. And it's written on the drug information sheet that once you reconstitute parenteral augmentin, it decomposes after 4 hours. Now, people keep this for like 72 to 3 days, and they will still be using it for the patient. They will assume they are using the right dose, but definitely the children will be getting suboptimal dose and will be complaining about the drug not working. So this is because they actually lack the basic knowledge about the antibiotics that they are using. A lot of time, doctors are under pressure, prescribers are under pressure to give at least a solution to a problem. A mother comes in, baby has a high-grade fever with running nose, and you're telling her, okay, from all we have seen now, is most likely a viral thing. Go home, there's no problem. The child will fight the infection, it will be over. No mother will actually accept that from doctors, so a lot of doctors will be to pressure. Let us give something so that at least to console the woman. Antibiotics is being abused. Another cause reason why or where misuse or abuse of antibiotics sets in is commercial interest of pharmaceutical company, in which case commercial interest of pharmaceutical companies, in which case once there's a new drug in the market or a broader spectrum antibiotics available in the market, the individuals that are actually producing this drug want to make gain from it. It is from our own end that we want to preserve the antibiotics and let's use it for patients that are actually in their need when other antibiotics that have been with us are not working again. But to the pharmaceutical company producing this drug, that is not their own major aim. They actually want to make interest from the drug that they are producing. So they will come out, they market it. Then a doctor prescribing in this clinic looks up, is the poster of that drug is saying on the biro is using or the jotter is using to write, then be like, okay, let me give this patient these antibiotics. And it might be too broad spectrum for the particular infection that they are being treated for. This might not be the fault of anyone here, but these are one of the drivers of misuse or abuse of antibiotics in our environment. One major other thing is the issue of poverty. In this environment, you tend to prescribe antibiotics for patients. They use it for first, second dose, then third dose, there's no money to buy, fourth, no money. They just write in the word, not available, not available. So the patient is actually using a suboptimal dose of your antibiotics, using it for a lesser duration, and this will amount to misuse or abuse. Then, of course, the indiscriminate use of antibiotics in animals, like I've said earlier, all these animals to have microorganisms in them, and by the time you expose these animals to antibiotics when it's not necessary, resistance develop in them, and one way or the other, it gets around to come back to human beings to cause infection. And because of the huge threats the antimicrobial resistance is posing globally, WHO has actually said that because no new drugs are in the pipeline for antibiotics, like I've said earlier, it's no longer profitable for companies. We are beginning to see multi-drug resistant pathogen causing treatment, causing infections in patients that you can't even get any antibiotics around to even treat them. So we have to do something about this, because we are, despite all the gain that we have achieved from antibiotics use in the past, it seems we are reversing back into a pre-antibiotic era where we are seeing infections that you can't even get any antibiotics to use for the patient. You, let me not say be helpless and watch patients die, especially in our environment where a few of the new available antibiotics are not even in the market for us to even buy. So to combat this antimicrobial resistant menace, it's a three-pillar approach has been advocated. The first one is to optimize the use of the existing antimicrobial agent that we have. The second thing is to prevent the transmission of this multi-drug resistant organism between patients. That is using a good infection control program in the hospital. Then the third one is to improve our environmental decontamination. Like the earlier speaker said, he said the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who finally succumbed to the infection with penicillin-resistant organism. This was said by Alex Adrafremi, like he said earlier. But I will bring this quotation to our own context now, that thoughtless person playing with antimicrobial agents is morally responsible for the deaths of the man who finally succumbed to infections from multi-drug resistant organisms. So we have to all be responsible for a good use of antimicrobial agents. We cannot afford to continue to play around with our antibiotics. And I believe everybody is a stakeholder in this realm, both the prescribers, the dispensers, the users. Everybody at large has to work together to ensure that we optimize the current antibiotics that we have at hand, so that we be able to prolong the lifespan of these antibiotics. One major way of achieving this optimization is the use of antimicrobial stewardship program. So what are these antimicrobial stewardship programs that we're talking about? They're actually a set of coordinated interprofessional efforts that are designed to promote timely and optimal selection, dose, and duration of antimicrobial agents for the best clinical outcome for treating and preventing infections with minimal toxicity to patients and minimal impact on resistance. Now, to summarize this in simple terms, it just means the use of the right antibiotics for the right patients at the right time, with the right dose, using the right routes, causing the least harm to that patient or to future patients. This can be applicable to animals too. Some animals genuinely need antibiotics because they have infections, but we have to ensure that it's used strictly for the ones that actually need these antibiotics, not for monetary gains. Now, the major aim of any antimicrobial stewardship program, it will be to, one, to optimize the existing antibiotics that we have, so that we'll be able to prolong the lifespan of these antibiotics and prevent development of resistance to them. The second thing is to promote the behavioral changes of antibiotics prescribers and dispensing practice in our environment, to improve the quality of care and patient outcome, to save unnecessary healthcare costs, because to manage multi-drug resistant organisms, we all agree with me that it's a very enormous tax with a lot of funds that are involved, to reduce the emergence, selection, and spread of these organisms, and to limit the adverse economic effect of these antimicrobial resistance. Now, I'll talk briefly about the strategies. There are numerous to mention, but I'll talk about a few. We have two core strategies that have been advocated globally that are already established. We are using various research. The other strategies are termed the supplemental strategies. Now, it's being advocated that any institution wanting to implement antimicrobial stewardship program can actually adopt one of these two core strategies and add other supplemental strategies to it. So I'll start by describing the first one. The first one is formulary restriction and prioritization. By formulary restriction and prioritization, we mean that antibiotics will be classified. The next slide shows us a form of classification that WHO is advocating for adopting. It's called AWARE. In this slide, we can see that antibiotics are classified. The available antibiotics are classified into three groups. The first one is the access group, in which case these antibiotics are believed to offer best therapeutic value and they have minimal potential for resistance. The second group are called the watch group. This group are indicated only for treating specific infective syndromes. Like a patient have methicillin resistant Staphylococcus aureus infection, you have to use vancomycin for it. So they are placed under the watch group. These are the set of antibiotics that are actually placed under restrictions, and somebody has to have authorization before you can actually prescribe them. Then because they are more prone to be a target for resistance, and thus they are prioritized in any antibiotic stewardship program. And the last group is termed the reserve group. These are the antibiotics of last resort. They are used for patients with life-threatening infection. So the antibiotics are being classified so that you'll be able to restrict certain antibiotics. Not all antibiotics are available in the hospital. Then you have to give a pre-authorization for prescription of the antibiotics that you have restricted. The second strategy, this strategy is a good one. It's actually cheaper when you compare with some of the other strategies. But one major problem of this strategy is that the physician especially wants to believe they are losing the autonomy to prescribe antibiotics for the patient. And that is one of the reasons why antimicrobial stewardship program has to be a team effort. Everybody has to be on the same page. You have to bring people to agree with the strategies that you're actually going to adopt. The second one is prospective audit with intervention and feedback. In this strategy, individuals, what is being done is you allow anybody, the prescribers to prescribe antibiotics as they are doing, but over time you audit the use of antibiotics in the hospital. People use a lot of methods to do this. One of the major ways of doing that is maybe a point prevalence survey of antibiotics used in the hospital. in which case you study the quality and the quantity of antibiotics that has been prescribed in your hospital. Then you give feedbacks to these prescribers with interventions. If you see that people are using or abusing or misusing certain class of antibiotics, then you educate them at that point. This strategy is actually is more acceptable to the physicians, but is usually more expensive and usually more labor intensive than the first one, the first core strategy. The other supplemental strategies I've listed: the streamlining, the escalation. This actually uses the microbiology results. Once you start a patient on empirical antibiotics, that is brush resum. Once you have a microbiology results, then you can de-escalate to with narrow spectrum antibiotics that the organism is sensitive to. For parenteral to oral conversion, patient is on IV quinolone, for example. Once the patient can take oral, you convert patient back to or the oral form. Since this antibiotic has a good bioavailability, the antibiotic other form, this form, the doctor has to fill a form while prescribing antibiotics to indicate the time when they're going to stop the use of antibiotics. Any reason to extend the use of these antibiotics, they have to come forward to defend the reasons why this has to be done. So then antimicrobial recycling, this has been used for antimicrobial agents like quinine that was being used to treat malaria a few years ago, but was abandoned, later reintroduced again, and it's the malaria parasite is now sensitive to them. So it's a good strategy that has been tried for some antibiotics. Then combination therapy, this is used majorly for TB, HIV patients, even for malaria. And the rationale behind this is to ensure that you're not exposing, they are majorly used for infections where there's a high parasite load, and you don't want to expose these organisms to a single antibiotic so that they won't understand how it works, then develop resistance to it easily. So the last one on the list is laboratory surveillance and feedback. This deals majorly with development of antibiogram for the hospital, in which case prescribers can actually go back to this document to see the antibiotic susceptibility pattern of the organism isolated from your own hospital, and to see the antibiotics that they can use for their patients anytime they have any infective syndrome. Having discussed this strategy briefly, because going to them might not be able to finish in 20 minutes, I will highlight a step in which when you want to implement antibiotic stewardship program for the hospital can be followed. The first step is that there must be a motivation for you to want to actually start this program. And one of the core motivations is for you to know what is actually on ground, what is even the problem in our environment. Let us identify what they are. And this can be done by measuring the quality and quantity of antibiotics that we use. Once you've identified that, we know the gaps that we want to fill, then move to the management level, where the management support is very important at this stage. You have to ensure that the antibiotic stewardship team has this power, has the expertise, has the credibility to actually lead the program. Then moving to the third step will be to set up and organize a team, a strong team, and the core members that must be there are the infectious disease pharmacists, infectious disease physicians, the clinical microbiologists, infection control expertise, and the IT expertise to help with a lot of information that will be managed in that committee. Although there can be other there must be other supportive members in the team, like the head of the clinical department, the prescribers, so that everybody will be on the same page and agree, so that we're able to agree on a single strategies that we're going to use. But before we choose this strategy, we want to set a goal. What is our objective? And we have to state this clearly, which is the next step, so that we bring all the stakeholders together, we agree clearly on what we want to do. Then the next step will be the fifth step will be to identify the intervention that you want to use for your own setting. Once everybody is on the same page, you have agreed on your objective, then you sit down to see the strategy that will work for your own environment before you, like I said earlier, you start with the core strategies before you start adding the supplemental strategies to them. These are strategies that have been used and proven across the globe. Then once you have chosen a strategy, the next step will be to educate and train the hospital community, the healthcare professionals, the patient, and the community at large about your strategy, and then so that the implementation will be very fruitful. And how you know that this is fruitful? You have to measure. You have to be able to use set up some parameters for you to be able to measure your success. One of the key things that is being used globally is to measure the rate of antimicrobial resistance development in your own hospital. For example, now you have used a strategy restricting the use of ceftriaxone in your hospital. After a year, you want to study the organisms that are being isolated in your hospital and see the resistant pattern to the ceftriaxone that you have already restricted the use. Most hospitals have done this, have a beautiful improvement in the increase in the susceptibility rate to that particular drug in their own hospital. Another thing that can be used is the Pathos Charts. The Pathos Chart is actually a word chart that studies the use of antibiotics per word. In this place, and anytime you're restricting any antibiotics, and you're checking the word to see which word is actually complying, which one is not complying, you'll be able to get and give feedback to the prescribers at that point so that the program will be successful. Then whatever it is strategy that we are using, whatever it is that we are using to measure, it is very important for us to communicate with one another. The individuals that are in the team must communicate with the end users of our program so that the program will be able to work. So we must give them clear and simple feedback on whatever strategy that we are using. All these strategies that we are choosing, the steps that we're using to achieve these antimicrobial stewardship program, they are aimed at achieving some core elements. The first thing will be that prescribing antibiotics when they are necessary is what you want to achieve. It's not giving antibiotics to anybody that does not need it. So we have to tell people to send investigate and see whether we are dealing with infectious diseases or not before we start prescribing antibiotics. And even if we start prescribing, once you have your investigation, then you can always stop or de-escalate. Then you have to prescribe antibiotics at the right dose for the right duration, like I've said earlier. You have to ensure that you assess patients using your culture results. We have to ensure that we monitor the rate of resistance in our environment and see the rate at which we are consuming antibiotics. We have to educate. Keep on educating. Sorry for that. It's essential for us to actually support one another in this realm by having good collaboration, because as we are all aware, we all have a role to play when it comes to the use of appropriate use of antibiotics. Now to my conclusion. Not enough new antimicrobial agents have been developed to fight these organisms. So the existing antimicrobial agents that are with us, we must ensure that we use them responsibly so that we're able to extend their lifespan, so that the patient that needs this drug will be able to get them. We won't give to those that don't need them. And this we can surely achieve through the use of a good antimicrobial stewardship program in our various hospitals. One last thing, collaboration between various teams in the hospital is very important. Collaboration between the antimicrobial stewardship program, the infection prevention control, pharmacy and therapeutic committee are very essential for us to be able to achieve to keep all our antibiotics that are available with us working. Thank you all for listening.